Welcome to EASD TV. Well, we've got up super early this morning to catch our first interview, so that's why it's very, very quiet in here. But I'm delighted to welcome David Leslie. David is at Barts in the UK, and we're going to talk about the different presentations, really, of type 1 diabetes. This was from a fascinating session about the evolving nature of type 1 diabetes presentations. So let's go back 10, 15 years. What was the generally accepted consensus about the way type 1 presented?
Well, people typically presented just as that little boy Leonard Thompson presented 100 years ago. At the age of 14, severe weight loss, nigh unto death, diabetic ketoacidosis, nearly died, and had the first injection of insulin. And that was really how people saw this disease. This was a childhood onset disease. It was acute, it was severe, and it could kill you immediately, but of course then perhaps later. Well, that has been the situation until fairly recently. That is to say, it's been the situation in the public image of type 1 diabetes, and it's been the situation in the profession's image of type 1 diabetes. But the reality is that type 1 diabetes actually is more common in adults than in children, more common in adults than in children, and more often than not, it presents initially without insulin being required in adults. That means you have a diabetes which is adult onset, non-insulin requiring, and can look terribly like type 2 diabetes. Some of us wrote an article which was entitled Type 1 Diabetes Masquerading as Type 2 Diabetes. And this has been a huge problem for the profession to get their heads around this and to manage these cases differently.
So what are the implications for diabetologists, but also, I suspect, people in primary care?
Well, it's been a big problem for primary care people, and indeed for everyone, really, because how do you diagnose these guys? You know, someone turns up to your clinic and he's an adult and he doesn't require insulin. How are you going to say, okay, he's got type 1 diabetes? And for general practitioners, it's a particular issue because they don't really even know this. So we need to just kind of get out there and preach this. It's an important point, and GPs, primary care physicians need to understand that there is this rethinking. It's been a huge issue in America, huge issue, because the insurance companies don't fund adults, or didn't fund adults, with type 1 diabetes because it didn't exist. It was a childhood disease. So you couldn't get a pump, you couldn't get your glucose monitors. It was a real issue. And JDRF in America, to their credit, realized this only a few years ago. And we had a meeting in New York, and then we subsequently produced an article to try and re-engage people with this reality.
So what should be the alerting flags to someone with type 1, an adult presenting with type 1 rather than type 2?
Yeah, well, we came up with this so-called ABC strategy, where A is for age and autoimmunity, B is for body mass index and background, C is for diabetes control and complications. So if you're young and you have a family history of the disease or of autoimmune disease, and you're lean, and you have poor glucose control, then you ought to really think,
is this type 1?
Is this type 1 diabetes? And you'll be wrong about 40% of the time because they're often obese at diagnosis. So it's, but at least it gives you a clue as to who you should be looking at. And we think increasingly maybe you should screen everyone. And I think eventually that's what will happen. We'll screen everyone.
And of course, that was what Emily Sims is calling for in the session that you're in is that universal screening is long overdue.
Yeah.
But when would you screen?
Well, you have to screen when they present.
No. But what I mean is universal screening when.
Right. Do you mean screening in terms of age before they get the disease?
Yes.
Oh, right. Okay. Well, Emily will have views on that. There are suggestions that you might start screening at the age of 2 years of age, 4 years, and then maybe 7, and so on.
And there's a suggestion that people should be screened automatically when they present at accident and emergency.
I think that's absolutely true. Yeah, you need that sort of screening. I mean, the slightly sad thing is we have now the facility, the ability to define this condition. We have the biomarkers, the genetic markers, and so on, to get a very clear handle on the sort of diabetes that person has who's sitting in front of you. But we don't use them. And we don't use them because they've been seen as expensive, and they've been seen as perhaps not that important because people didn't understand that they were getting it wrong. They always thought they got it right with type 1. We know it's childhood onset. We know it's severe. I know how to diagnose type 1. And then you discover, well, you don't actually. You don't.
So really the tale that we're hearing more and more is of these endotypes, these subtypes in type 1.
Yeah.
And do you think that there is still more to be discovered?
Well, yes, absolutely. I mean, the endotypes, I call them fuzzy endotypes because there's a lot of variation, I think, in these endotypes. In childhood onset disease, I'm a strong believer, having probably originally suggested it, that the age at onset of this disease is indeed very young. And Oka Learnmark was talking yesterday about people showing changes by 3 months of age. But it looks to me like a point source exposure, just like an epidemic. You get something happening very early age, and then you get a peak, and then it tails off. And I think, the endotype associated with very young children, the so-called insulin autoantibody associated endotype, was seen as people under the age of 7. Well, that's not true. It goes on to 13, 14, even into adult life. So there's a long tail, but I think it is a point source exposure like an epidemic, that type. But the type I'm interested in, which is the GAD-associated autoantibodies, GAD being glutamic acid decarboxylase, the molecule which originally identified by Oka Learnmark, that type goes on for a long time. And that's the type which actually accounts in the main for adults having so much type 1 diabetes. It's a broad endotype. For many, it goes on for 6 decades. So I think this endotype will change. We'll start dividing it up again beyond glutamic acid decarboxylase antibodies. We already know that IA2 antibodies are associated with progression to the disease and a different genotype from GAD, and yet they tend to occur in early adult life, adolescence. So we're pretty clear that there will be other types. Yeah.
Fascinating insight, David Leslie. Thank you so much. Well, there's so much more for you on EASD TV. I look forward to being with you once again soon.